Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Joining me today is Dr. Aaron Katz, a good friend and international leader in urology. He's professor and chairman of urology at NYU Winthrop. Aaron's going to share with us experience that centers around evaluation and treatment of men who have biochemical failure following radiation therapy. Aaron, thanks for being with us.
Well, thank you so much, David. It's a great pleasure to be with you here on Urology Grand Rounds and to take this opportunity to go over what I think is a very important topic for urologists, radiation oncologists, and certainly for our young residents as well, to learn about how to evaluate and manage men with a biochemical recurrence after radiotherapy. For this particular talk, I have no disclosures. And as we all know, radiation therapy is clearly one of the standard options for men with who have localized prostate cancer, especially men with early stage, whether it be low or intermediate risk. It still remains a main treatment, although for men with early stage low risk cancers, we are seeing many more of the men choosing active surveillance. But for those with intermediate and high risk features, external beam remains one of the standard options. Unfortunately, we still see around 20 to 50% of the men will develop a biochemical failure within 10 years. And if we biopsy these men, it's my own experience that if men are failing by the classic Astro or Phoenix definition, that a significant proportion of these men, nearly 70% of these failures, will have local residual cancer or relapsed cancer. And without further treatment, the concern here is that these cancers will clinically progress and give men urinary symptoms of urinary obstruction, hematuria, chronic pelvic or rectal pain, which will obviously negatively affect their quality of life. But what's more concerning is the potential source of these cells, which are tumor de-differentiated. They're more aggressive, and they're more likely to lead to systemic dissemination and lead to the demise of the patient. So let's ask ourselves, why do patients fail radiation? And many studies have looked at this question, and clearly one of the causes is in the past we were using inadequate doses. And a lot of studies have shown that the higher doses we go to, whether it be 75 or 80 gray for external beam or IMRT, we are able to have less biochemical failures. But on the reverse side, when we go to our higher doses, what do we see? We see higher GU and GI side effects. There can also be new tumor forms. It's possible that the tumors that we initially treated were eradicated, but because these patients have a propensity, whether it be due to biological factors, somatic mutations, they were exposed to, especially in New York, we see a lot of men that were exposed at the World Trade Center at 9/11. In that tragedy, they're at risk for prostate cancer, men that were in Vietnam that have been exposed to Agent Orange. So they have a higher likelihood of developing newer cancers. And there's also been a lot of work in the laboratory to show that there may be some biological and genetic factors, oncogene expressions, NMYC, P53, and other somatic mutations that may cause these cells to become radio-resistant. I often see men that are understaged. Men present to me with a Gleason 8 or 9 cancer and a PSA of 30 to 50 that undergo radiation therapy. Despite having a negative imaging with a CT scan and bone scan, they never had their lymph node sampled. They didn't undergo a laparoscopic or open pelvic lymph node dissection. They didn't have a seminal vesicle biopsy. And so they're understaged. And this is also going to give them a likelihood of failure after radiotherapy. The known predictors are the obvious ones, the obvious players that we see for any type of treatment. Their initial PSA, their initial Gleason score, their initial clinical stage, leading to their overall risk stratification. The other thing that we're seeing recently is that their pre-radiation MRI, and many of us are using MRI not only to help in our biopsy strategies and follow patients on surveillance, but before radiotherapy, patients get an MRI, and the higher the PIRAD score may be an independent predictor of whether or not these patients are going to fail. And unfortunately, when patients do fail in the United States and throughout the world, actually, local salvage therapy is infrequently offered. And it may be that the patients with a rising PSA after radiotherapy without metastatic disease are often treated just with palliative intent. Most of the men in this country are offered either observation, if the PSA doubling time is rather long and the PSA velocities are slow, or the knee-jerk reaction by many urologists in the country is to give androgen deprivation therapy, whether that be in a continuous fashion or intermittently. We also know that many of the patients are offered radiotherapy instead of radical surgery because they were older. Initially, they had more comorbidities. And so now that when they're failing radiation therapy years down the line, obviously they're going to be a little bit more older. They may have more or existing comorbidities. So patients may not want to undergo salvage therapy. And of course, there's concerns about the potential toxicity from local therapies. So overall, about 25% of the patients with biochemical failure are managed with observation, 70% are offered androgen deprivation therapy, and less than 5% of the patients actually undergo some potentially curative form of local salvage therapy. Now, I just want to remind everyone that just because your PSA is going up does not necessarily mean that you have cancer. In my experience, and other studies have shown this, it's about a 70% chance that you will have local or residual disease if you go ahead and biopsy these men if they fail by the Astra or the Phoenix definition. But it could be that the cancer was eradicated and you have BPH. So the BPH tissue may also express a PSA. It could be that the disease was eradicated locally, but now you're dealing with metastatic disease. And there is this well-known bounce phenomenon, most characteristically seen, especially when you place fiducial markers or after brachytherapy, where you can have this PSA bounce due to inflammation that can occur anywhere between 6 to 12 months or even 2 years out after radiotherapy. And then there's inflammation. And if there's inflammation due to many patients that have had brachytherapy or even IMRT, where you have urethral inflammation, patients may have urinary retention, increased lower urinary tract symptoms. Always check a post-void residual volume in these patients, as they are susceptible to a urinary tract infection, which again may cause a rise in their PSA. So in my experience, radiation recurrences happen. They do happen, not that often, and thankfully we have newer modalities of treating patients with radiotherapy, with higher doses, hypofractionation, with SBRT, but they clearly do happen, and they can occur. And actually, they can occur very early. And sometimes if they occur within the first 18 months and your PSA is rising, be aware. Be aware that there may be progression, and there may be signs that they don't have metastatic disease. They may not tell you that they have back pain or bone pain, but in fact they do. And you may want to get early imaging tests, and I would encourage you to do that. And if the patients had combined androgen deprivation therapy with their radiation therapy, beyond just a PSA, get a testosterone level. And their PSAs may be low, but if they're slowly rising and their testosterone levels have not recovered, well, then maybe you may be dealing with something more ominous there because their testosterone levels are not yet normalized. So always be aware of their testosterone level and get a PSA as well. Sometimes the PSA recurrences may occur late, sometimes 2 to 10 years, and sometimes it's the only sign is their PSA rise. They may have no symptoms, but rarely their digital rectal examination can be give you great information, and the DRE can be abnormal. So be wise about your PSA in the post-radiated patient. Look at your PSA nadir. If your nadir PSA didn't drop below 0.5 and their PSAs are rising, definitely get an image test. And know your PSA kinetics. Know your PSA nadir. Look at your PSA doubling time. Short PSA doubling times between 3 and 6 months are very concerning and may indicate that the patient, A, will not do well with salvage therapy, and B, may likely have a progression of metastatic disease. Look at PSA velocity, and when evaluating these patients, look back. If you haven't treated this patient, get the information. Look back at their Gleason score and look back at their pre-radiated PSA. So when you're thinking about a patient for salvage therapy, obviously we're going to look at the patient's age and their life expectancy. One of the things that you should not do, I don't believe, is to consider the patient for salvage therapy if they're older, if they're in their late 80s, if their life expectancy is short, if they have a lot of comorbidities, coronary artery disease, hypertension that are not well controlled. Don't even do biopsies on these patients, because if you're not going to offer them salvage therapy, if you're not going to consider them a candidate for salvage therapy, then there's no point in rebiopsying them. I think you should image them, and if their image is showing that there's progression of metastatic disease, to start them on hormonal therapy. But if they're not going to be a candidate for salvage therapy, no reason to biopsy them. And determine whether or not the patient is potentially curable based upon their PSA and their initial Gleason score in PSA. And then this will help you isolate the difference between a local recurrence and one that has a systemic spread. And obviously, cancer biology is always important. And sometimes it's difficult to interpret the post-irradiated biopsy. In fact, the typical classic Gleason score grading system should not be applied to the biopsies where there is irradiated tissue, where they say radiation effect. There's where you should not use your Gleason score, but you can use the Gleason score where there has been no radiation effect on the biopsy. So you can ask your pathologist for a Gleason score in those post-radiated biopsies. When you're getting your history and physical, this is very important to determine whether or not before or after the patient had a TURP. And I can tell you from my own experience that if a patient had a TURP or needed some form of a procedure for a bladder outlet obstruction, or had a stricture, developed a stricture from radiation, these patients are going to be much more difficult to manage when you start talking about salvage therapy, and their likelihood of having an adverse event such as urinary incontinence is going to be much higher. So obtain a baseline IPSS score on all these patients. If it's high, before you embark on a salvage therapy, consider alpha blockade and always get a post-void residual volume. Understand their GI history. Did they have rectal bleeding? Did they have pain? Did they have diarrhea when they underwent the radiotherapy? This can be very important beyond looking at their medical illnesses and oncological history, as I mentioned. And again, I think that digital rectal examination is a must here and can be very helpful. Even when the PSAs are low, you can find DREs that are abnormal and may lead you to an earlier biopsy. Now, this is the NCCN guidelines that we currently have to help us to stratify how we manage patients after the patient has either a PSA persistence recurrence or, as I just mentioned, a positive digital rectal exam. Now, for this talk, I'm not going to focus on those patients that are not a candidate for local therapy, but if their bone imaging, as I mentioned, looks like it's positive and there's progression, then you can go on to hormonal therapy. But if the patient is a candidate for local therapy, if their original clinical stage is a T1 or T2 with no evidence of nodal disease, and their life expectancy is reasonable, and their PSAs are relatively low, and I don't have time to go into all the studies, but the majority of studies will show you, not surprisingly, the lower the PSA at the time of recurrence, the better the patients are going to do. Here's what you should do. Understand your doubling time, as I mentioned. The guidelines say chest X-ray or chest CT, and to be honest with you, in my own practice, I have not done this unless I do. I do a chest X-ray before I schedule a patient for a salvage therapy in the operating room, but I don't typically do that. I will get an image test, though, before my biopsy, and I've relied on CAT scan and bone scan, but I will tell you that there's some great new studies now that I've relied on that I think are much more sensitive than the classic CAT scan or bone scan, and that is the Axeman scan, which relies on a radionucleotide leucine, an amino acid, the PSMA, which is not here on the guidelines yet, but the gallium PSMA scan, PET scan, which is not available in many studies, does seem to have very high sensitivity, especially in patients with low PSA values, even less than 0.5. The sensitivity is quite high. And the choline PET scan, again, not available in many centers. There are a few in the country that can actually determine with very good sensitivity whether or not the patient has lymph node involvement. Assuming that the scans are negative, I do still like to get a prostate MRI. I will caution you here. Although prostate MRI in the untreated radiated patient can be very reliable in terms of its PIRAD system and for use in fusion biopsy, first of all, the PIRAD system has not been validated in the radiated patient setting, so you need to know that. And in addition, after radiotherapy, the prostate becomes smaller, it becomes fibrotic, and that classic transition and peripheral zone differentiation may be lost. And in my own experience, I've seen many patients that have come to me with a completely negative looking MRI and biopsy showing significant high-grade disease. So don't be fooled. If your PSAs are going up and your metastatic evaluation is negative, even though your MRI is negative, biopsy that patient. And of course, if the MRI does show a specific lesion, you can biopsy additional target areas as well with your fusion technology. And if the biopsies are positive and the distant metastatic disease studies are negative, then you've got the options that I'm going to go through briefly over the next few slides, whether or not we observe the patient, which is reasonable, I think, with patients with limited life expectancy or longer PSA doubling times, or biopsies that show relatively small, insignificant cancers. Yes, it's reasonable to observe it. Yes, I've done it in my practice many times. Radical prostatectomy in the salvage setting, salvage cryotherapy, salvage HIFU, or salvage brachytherapy are all options. It becomes confusing for the patient and the clinician, actually, as to when you get a negative biopsy and the PSAs are going up and the distant metastases are negative. What do you do then? Well, the guidelines basically say that you can either observe the patient or place the patient on androgen deprivation therapy, or if there's a clinical trial, fine. I'll tell you my own experience. If I'm worried and the biopsies don't show anything and the image tests absolutely are clean, I'll start the patient on androgen deprivation therapy, even for a short period of time, which I think can kind of reset the clock for many patients, get their PSAs down, and do intermittent therapy, which I think it can be quite helpful, especially in the patients without metastatic disease. So I've mentioned this, and these are the things that you want to make sure that you document in your charts with patients with a rising PSA. You want to look at the type of radiation that they had, where was the radiation performed, the dose that they received, which can be important, and I'll show you why in a moment, whether or not they got hormones or if they're still on hormonal therapy, and are you dealing with a castrate-resistant disease, which is very concerning. And I would tell you that I typically have stayed away from offering these patients salvage therapy if they are castrate-resistant. I don't think that it works all that well. Look at their risk category and understand if they've had prior urological procedures, especially TURPs. And then post-radiation therapy. How's their PSA nadir, the doubling time? Did they have toxicity? What's their PSA recently? Have they had a PSA recently? I see patients come in and they haven't had a PSA in a year, and they said, oh, my PSA was rising and I haven't had a PSA in a year. If they're on finasteride or hormones, or they have comorbidities, look at their shim and IPSS, especially. This is very key when you're going to offer patient salvage therapy, because both of these are going to potentially going to take a hit. The IPSS and definitely the shim, no matter what salvage therapy you offer these patients, their shim scores are going to go down. You want to look at your imaging and biopsy, as I mentioned. So here's the therapeutic options for our patients. What do we have to offer? So I broke it down into two broad categories. One, I think, is the non-curative. Not that it's inferior necessarily, but it's not going to eradicate the disease. A lot of patients say, look, I went through radiation therapy, now the cancer's come back. It's a high-grade cancer, which I will tell you in my experience, many of these patients that start out with a Gleason 6 or 7 are upgraded now to a Gleason 8 or 9. They want the cancer out, so they want something that's going to be potentially, and I say here potentially curative. But the non-curatives, either surveillance or hormonal therapy, as I mentioned, either continuous or intermittent. And then the potentially curative, the salvage radical, salvage brachy, salvage cryo, salvage HIFU, and then something else that's coming down the pike and I think is rather interesting. I put a couple of slides at the end, the irreversible electroporation. So let's talk about salvage radical prostatectomy, and many of you are doing radical prostatectomies in your practice, and you're probably great at it and love doing a robotic surgery. And certainly robotic surgery has made a tremendous impact in how our patients are doing in terms of getting them out of the hospital sooner, less blood loss, and less time to maintaining and having complete urinary control. But what about in the salvage setting? It's not the same. The most frequent complication, and look at these complication rates carefully, the most frequent complication of salvage radical prostatectomy, a lot of neck contractures, up to 25%, and leaks and anastomotic disruptions, 15%. You do not see that in the untreated patient. Rectal injuries can occur, 5 to 10%. These are dangerous, and these can cause significant change in the lifestyle, not only of the patient, but of as you as a physician. These are horrible, and they can progress to rectal fistula, requiring secondary and third procedures with possible gracilis muscle flaps and omental, putting a piece of omentum down, or even abscesses. Many these patients may develop grade 3 to 4 complications, and obviously they're going to be much higher in the salvage setting, and that's because you get this fusion of the prostate onto the rectum, and it's very difficult, even in robotic surgery, to take these prostates out. And in the long term, urinary incontinence rates, I mean, you don't see this high incontinence rates in the untreated patient. You just don't. I've looked at the SEER data, and clearly the length of stay, the hospital readmission rates are much higher in the salvage when compared to primary radical prostatectomy. And there was a recent study that looked at the National Cancer Database and showed and demonstrated that if you're going to do these procedures, you're probably best off doing them at the academic facility. Now, when we first started doing robotic surgery, this is where most of these procedures were done. They were done at most of them were done at the academics, and then it kind of filtered into the community. I think for the salvage setting, it's best, and the NCDB showed this, that if they're done at the academic facility, the risk of prolonged stay was significantly reduced. So think twice about them. The patients do okay. The biochemical-free survival rates are reasonable. 37 to 65% will stay undetectable, and their cancer-specific survival rates are pretty good. I mean, this is what the patients are concerned about. They've had a relapse in radiation therapy. What is my chances of living 5 years, 10 years? So these numbers are not horrible. We clearly show that the recent study that I looked at, looking at robotic surgery, did show that the early outcomes were pretty good. The 3-year biochemical-free relapse rates were 80 to 85%. And, the obvious advantages of using a robot are going to be better tissue plane recognition in the radiated areas with 3D magnification and less blood loss. So if you're going to do them, you're probably best off starting them with doing it with robotics. Now, what about doing additional radiation? I mean, does that make any sense to do additional radiation? It seems counterintuitive to me to deliver more radiation in a patient that may have a radiation-resistant tumor, but not all tumors are inherently radioresistant. And it could be, and this is where dose is key, and this is where you need to rely heavily, not that you're going to be doing brachytherapy as a urologist, but you need to go back to your radiation oncology colleagues, see where the initial radiation was delivered, how much was the dose, and was the dose sufficient? Was there, as Dr. Many of the people that are doing brachytherapy talk about, dose following brachytherapy, was there a proper dose? Was there a proper dose with IMRT or even with SBRT? So if the dose was low in one specific area, and this is an area where you may want to just do focal brachytherapy, you could certainly do that. I-125 is most commonly used, and certainly the patients that you're going to consider for salvage brachytherapy should have minimal side effects following their initial XBRT, because if they went through external beam initially and suffered from radiation proctitis or bleeding, you do not want to deliver more radiation at this time for fear of causing more rectal damage. Overall, biochemical-free survival rates, not bad. 50%, range from 34 to 77%. And as I mentioned earlier, and some of the studies have shown this, that for patients that are on androgen deprivation therapy for a prolonged period of time after the radiation, and now having a rising PSA, get the testosterone level, and if their castrate levels and their PSAs are rising, indicating castrate-resistant cancer, their outcomes are not going to be as good as other patients. So keep that in mind. If you're going to do additional radiation therapy, you may want to consider this spacer that many of the radiation oncologists and urologists are placing transperineally to give you a little more space between the prostate and the rectum when you're delivering more radiation therapy. And I think it's reasonable, although I've heard anecdotal experience where it may be more difficult to place these spacers in irradiated tissue. What about salvage brachytherapy using HDR? There are some centers that are doing HDR for brachytherapy in a salvage setting. This involves the implantation, again, transperineally, of placing in catheters or needles into the prostate under ultrasound guidance using irradiated wires, and they are getting passed at 3 millimeter intervals. The catheters can be placed to also include any area where you feel there may be extracapsular extension or if there is seminal vesicle involvement. And there's a few series out there in the literature about this. The efficacy overall, I think, is equivalent to the LDR brachytherapy, and with the brachytherapy, there seems to be less GU and GI toxicity. I've had a lot of experience in my career. I actually started my career doing a lot of salvage cryoablation, still continue to do it this day, although the technology has changed quite a bit. This is using cold technology to eradicate tumors that have recurred after radiotherapy. Again, transperineally placed needles or cryoprobes can be put into the prostate. It's an outpatient procedure. There are 2 commercially available systems in the United States. One uses 17-gauge needles. The other uses 2.4 millimeter cryoprobes. They basically do the same thing by delivering argon to freeze and kill cancer. The advantages of this system is that it can allow you to change the extent of the ice ball, especially if you're dealing with rather small prostates. Some of the prostates that I've irradiated, that have been irradiated, that I've treated, are less than 20 grams. So this system allows you to adjust the ice ball. This system is a very thin needle and also has multiple thermal sensors, so it can measure the temperature at multiple points along the needle in these thermal sensors. And this is an example of a patient where we're doing a focal ablation of the prostate in a salvage setting on the right side. You can see this is these are the needles that are going in. There's 6 of them. These T1 to T4 are thermocouples, and this is a graphic demonstration showing that the temperature in the prostate and in the cancer is going below -40, which is what you would like to ensure that the tumors are killed, -40 degrees or below. And this is the temperature in the sphincter, which remains above 20 degrees. And in my own personal experience doing several thousand of these, if your temperature remains warm above 20, your patients will be continent. And almost immediately once the catheter comes out. This is an example of what it looks like in the operating room. Patients are brought in, they're given either spinal or general anesthesia. It's all done transperineally. The needles and thermocouples go through a grid. Argon gas flows through. During the procedure, there is a warming device, which I don't really show you here. Here's actually the warming device, which warms the urethra throughout the case. The case takes about an hour and 20 minutes, and the needles and thermocouples come out, the warmer comes out, and a catheter gets replaced and stays in. In my experience, in my own practice, I do these procedures on a Thursday, and the catheter comes out on Monday. The likelihood of needing a second catheter is extremely rare, less than 5% of the cases. Urinary incontinence rates are much lower than in the salvage radical prostatectomy series, although some patients may experience increasing lower urinary tract symptoms for several months, and I place all the patients on alpha blockers if they hadn't been on one. One of the downsides here is new onset erectile dysfunction, which I think exists for radical prostatectomy as well as for cryotherapy. I think we need to be honest and real with our patients and letting them know that new onset erectile dysfunction will occur in an overwhelming majority of patients. Not so high if we do focal therapy, but certainly if we're going to do a complete gland ablation, new onset erectile dysfunction will occur in over 90%. Fistula rate, thankfully, has dropped down to less than 1%, as well as GI toxicity. Stricture rate, retention rate, and the need for TUR are all low. And thankfully, I think in my last probably 1,000 cases, I have not transfused a single patient, nor should you if you enter the prostate and the needles don't enter the bladder. There may be some transient hematuria in the recovery room, but other than that, that should be it. It's approved in 2001. I was helpful in getting this modality approved through Medicare, and most commercial insurance carriers will pay for it. It's outpatient, it's urology friendly, it requires the placement of the needles, a cystoscopy, and temperature monitoring, and it's fairly friendly for urologists. As I mentioned, there's 2 commercially available systems. There's a lot of literature, there's a lot of publications in the literature, single center, multi-center, and something from what's called the Cryo Online Database Registry. And you can read all of those publications if you'd like. But overall, to date, as we stand here with the new technology, the overall morbidity of these procedures is quite low. This is my publication from 2013. This is most of my experience when I was at Columbia before I came over to the NYU campus, looking at my first 328 patients, and the 5- and 10-year disease-specific survival projected out with Kaplan-Meier is pretty good, 91% and 79%. And the patients can also be treated if they've had SBRT, brachytherapy, or HDR. So any form can be done. What about focal salvage therapy? Now that we're able to map these cancers out rather well, we're seeing a number of patients that come back with just one small area of cancer. Rather than treating the entire gland, we can now use focal therapy. It can be done with cryo, it can be done with high-intensity focused ultrasound, which is another form of therapy that's being employed in the salvage setting. There's a lot of experience in Europe on HIFU, also an outpatient procedure using high-intensity ultrasound waves to focus in on the prostate. My experience and what I've seen is a higher rate of urethral morbidity in these procedures. And there's some physicians that are doing a lot of laser procedures, either MR-guided or transperineally, that can be done under local or just sedation. Unfortunately, right now in the United States, you see here cash for HIFU and for laser. Patients need to pay for it. The cryo is the only one that is currently Medicare approved in this country. Just wanted to run through and end a couple of slides left, but just wanted to show you a case of a focal salvage cryotherapy cancer case that we had of a 68-year-old gentleman with a rising PSA to 5.8. He had radiation therapy about 10 years ago, and his doubling time was 2 years. Did an MRI, which did show an area on the left side that was concerning. The MRI on the right side was negative. MRI fusion biopsy and 12-core systemic biopsy showed systematic biopsy just demonstrated left-sided high-grade cancer recurrent in several cores, and the biopsy on the right side were negative. This is an example. We did a focal cryotherapy, so you can see this hypoechoic area on the left side is the ice ball. This leading hyperechoic area is the edge of the ice ball. And so we're just freezing this side. This is where the urethral warmer would be. And then in the next slide, the ice ball is all the way down. One of the other features that we're doing is we're using color Doppler now, which most of the ultrasounds have equipped with a color Doppler, a pulse Doppler, power Doppler, that you can monitor the pulse within the neurovascular bundle to make sure that that stays active and the patients will, in greater likelihood, remain potent after the procedure. And this is the complete ablation on the left side. You can see the ice ball just trending down towards the anterior rectal wall. This is the urethral warmer here, and this is a complete left-sided focal ablation. MRI was done a year later, showing that there's no enhancement in the area of the ablation. The patient had done rather well. His PSA dropped down rather dramatically to 0.4. Repeat biopsy showed no cancer. Obviously, I'm showing you a great result on this patient, and the shim score was quite high at 24 without the need of any PD-5 inhibitors. So these patients that get focal salvage or total, either way, irrespective of whether or not we're focally ablating them or giving them a total ablation, they get a Foley catheter for 4 nights, they get an antibiotic for 5 days, alpha blockers for a month, and we follow them the same way. PSA and digital exam every 3 months, in 3 months, and then every 3 months for 2 years, and then every 6 months thereafter. At each visit, they get an IPSS and a shim. And then we have not been routinely biopsying them just based upon their PSA rising or an abnormal MRI. And this was published a couple of months ago in 385 men in the Journal of Cancer and Clinical General Cancer, showing that the oncological outcomes comparing salvage and focal cryotherapy were quite similar. What they did show was that in the focal, and I've found this as well, that there's reduced urinary retention. Although I have not found urinary retention to be much of a problem, even in the total salvage ablation patients. So the patient should consider cryo. There's no hospital stay, no transfusions, no delayed long-term complications or risk of secondary malignancy. It can be repeated in a salvage setting, but I've only done it a handful of times and get rather nervous when you have to repeat on a salvage setting, but it can be done. Incontinence rates are low, minimal anesthesia, and a great return to life. And the focus, the HIFU studies that have been done, this is a paper that was just published a couple of years ago looking at 418 patients with a registry in Europe, looking at the Phoenix definition and looking at HIFU as a total whole gland salvage ablation. And all these patients had biochemical recurrence after radiotherapy with a negative metastatic evaluation. The biopsies were done in 60% of the patients after this, and the negative biopsy rate was pretty good, 74%. The 5-year biochemical free survival rate was okay, 49%. Clearly, it's going to be better in the lower risk patients than in the higher risk patients, but unfortunately, they had a significant number of incontinence rates, and their fistula rates were less than 1%. And I just want to end on this one topic, this irreversible electroporation. A number of studies are ongoing in the United States, not currently approved yet, but I think it's an interesting area of investigation, both on the primary and the salvage side, actually. It's an energy-based system that produces tissue ablation by delivering short, high-voltage electrical pulses delivered transperineally that are delivered through these metal needle electrodes. And it can be used as a salvage treatment in patients with recurrent disease. It's undergoing investigation, and some of the studies that are coming out of Memorial Sloan Kettering look favorable. So I want to just leave you with some additional thoughts. Certainly, I don't know if in your area, but certainly in the New York area, we are seeing newer forms of radiation, SBRT, that are showing great promise. And at my own institution, we're using something called CyberKnife. It's hypofractionated. It's ultrafractionated in the sense that we're only able, the patients have to have radiation therapy for only 5 days, delivered at higher doses. But we are still seeing cases of regional recurrence. So even though we're doing better with our radiation and we understand more about dose, you will continue to see these patients in your practice. I urge you to scan them early, especially if they are showing signs of PSA relapse. MRI can be helpful in select number of patients, but remember, sometimes the MRI can be misleading, especially in this patient population. And I hope this lesson that I've gone over with you can help you inform your patients about the options that exist if recurrent cancer should arise. Salvage radical prostatectomy, the robotic or open, should be considered, I think, but in rare cases. And again, I think it should be done in the experienced hands. If you haven't done many robotic surgeries or even open radical prostatectomies, these are not the cases that you want to be taken on. And so refer to them. If you feel that the patient is a good candidate for radical surgery, refer them to an academic center or someone in your area that has a lot of experience. In my own experience, I've done salvage cryotherapy for many years now and feel that the outcomes and the overall quality of life are excellent. And I have not seen in the data that I have reviewed that salvage cryotherapy versus salvage radical prostatectomy, that there's any difference in the overall survival. And always think about the quality of life for your patients. I thank you for the opportunity, and thank you very much, and I hope this was helpful to you and your patients.
Aaron, thank you. What a great in detail overview about everything you need to know to deal with this challenge, and we all see it. And I think that we're many times delay doing intervention, workups, and things like that till it's too late in these patients, and they do have a second chance. I've always said, though, you can't take somebody that was not a good candidate for radiation, then have them fail and expect to salvage them and improve their survival and quality of life. It has to be somebody that was a good candidate to begin with, and for some reason they exhibit a failure. A couple, there's not much I can ask after that terrific discussion, but just give us some insight on biopsies. As you know, we're interested in the mapping biopsy and more intensive biopsies. What should the urologist do that sees a person that fails radiation? They by the Phoenix definition, they have the rises, they have negative workups. Let's say they've had an oxymum scan that might show some activity in the prostate, and you got them early. What kind of biopsies do you do? 12-core, directed mapping?
Yeah, I like to do the 12-core biopsy and then direct infusion biopsy if the MRI is showing something. I often will ask the patient again about if they've had any rectal toxicity or if they've had any trouble with their initial biopsy, and then we'll switch over to a transperineal approach. There have been reports of patients that are having bad outcomes from their biopsy after radiotherapy. Some of the patients have developed an abscess. There have been reports of fistula from that. I haven't personally seen it, but I think it can happen. So again, when talking to your patient, again, a thorough history is important. What was your initial experience like? Did you have any infection? Did you have any rectal toxicity from the radiation? If so, go to transperineal mapping biopsy. That makes sense to me.
You've had a lot of experience with cryotherapy, and so have I, but when we go around and talk to urologists about this, there doesn't seem to be a lot of interest. There's some baggage hanging overhead or something. Has that been your feelings, and do you experience that?
I think that cryotherapy is on the rise. I think patients are looking for minimally invasive options, and especially for urologists that didn't train in the robotic era and don't have someone in their practice that does robotics, and or they want to take on prostate cancer treatment themselves. I think cryotherapy still has a great format for them. There's some training involved, like anything else, but again, I always emphasize that if you're doing your own ultrasounds and you're not hiring an ultrasound tech to come into your office, but you yourself are doing your own ultrasounds, you understand ultrasound, maybe you've been involved with brachytherapy with your radiation oncologist, you can take that experience and apply it to cryotherapy.
I think one of the things we have to remember is, I was going to say, one of the things that we have to remember, you don't want to start your cryotherapy experience with salvage cryotherapy. Many times the prostate size is 15, 20 grams, and you can get into a lot of trouble, and the fistulas that I've seen happen have been in these sorts of patients.
The other thing that we're seeing now, because... you go ahead.
Go ahead.
No, I was just going to say that now we're doing so many fusion biopsies now, and we're detecting these cancers by MRI oftentimes. And, patients don't need whole gland treatment. They want treatment, but they don't want radiation. They don't need whole gland treatment. So focal therapy, whether it be in the primary or in the salvage setting, really makes a lot of sense for so many people. And their quality of life is excellent. They're treated within an hour. They go home. They have the catheter in for a few nights, and they're done. And, the nice thing about cryo, talking about it in the primary setting for a moment, is that you don't really burn any bridges. So you did a focal cryo and somebody, did well for 5 years, and then they, the PSAs were rising and they had a recurrence. You could always freeze them again. You could always offer them radiation, or you could always take out their prostate. So you don't really, burn any bridges or freeze any tunnels, if you will, by doing a focal ablation. So I think it offers a nice, I continue to see patients that were told, oh, Dr. Katz, they told me I had to have radical surgery, 10, 15 years ago, and you just did that focal freeze on me, and that's all I had. And, they've done very well. So I think it's a nice thing to add to your practice. especially if you're in a large group practice where other guys are doing robotics and maybe you're not, and they're doing a lot of prostate biopsies and you're seeing these focal lesions. I think this technology can be very nice to add to your everyday practice.
The other thing, surgery-wise, is a lost start is to do perineal prostatectomy. So these are perfect patients to do that in. I've done several hundred over the years, but you don't find many people doing that now. They're gravitating towards robots and other things, which is fine.
Well,
there are some distinct advantages, and we can get the patient home the same night too. So, Aaron, this has been a great conversation. We appreciate all your contributions you have made over the years in many aspects. And we'll have to get together later and talk about some of the many things that you've done in the men's health arena. So, again, thanks for everything you've done. And I know that those that are listening feel very well educated on how to deal with this now. Thanks.
Thank you so much. It's been an honor. Thank you. Be well.